Investigations and treatment of benign biliary strictures. Benign biliary strictures, BBS, are narrowing of the bile ducts due to non-malignant causes. Accurate diagnosis and appropriate treatment are essential to prevent complications such as cholangitis, biliary cirrhosis, or secondary biliary scarring. Below are the details of investigations and treatment options for benign biliary strictures. PAC investigations. 1. Clinical history and physical examination. Symptoms: jaundice, itching, abdominal pain, fever, cholangitis, and pale stools. Risk factors: history of surgery, e.g., cholecystectomy, pancreatitis, or biliary tract interventions. 2. Laboratory tests: liver function tests, LFTs, elevated alkaline phosphatase, gamma-glutamyl transferase, GGT, and bilirubin levels. Inflammatory markers: elevated white blood cell count and C-reactive protein, CRP, in cases of cholangitis. 3. Imaging studies: ultrasound, US, initial screening for bile duct dilation and liver abnormalities. Magnetic resonance cholangiopancreatography, MRCP, non-invasive evaluation of the biliary tree. Computed tomography, CT, to assess surrounding structures and rule out malignancy. Endoscopic ultrasound, EUS, useful in differentiating benign from malignant strictures. 4. Direct biliary imaging, endoscopic retrograde cholangiopancreatography, ERCP, allows direct visualization, biopsy, and therapeutic interventions. Percutaneous transhepatic cholangiography, PTC, alternative when ERCP is not feasible. 5. Histopathological and cytological evaluation, brush cytology, biopsy, or fine needle aspiration, FNA, during ERCP or EUS to rule out malignancy. 6. Specialized tests, IgG4 levels, to assess for autoimmune pancreatitis or IgG4-related sclerosing cholangitis. Stool studies, rule out parasitic infections like Clonorchis or Fasciola. Treatment. Treatment aims to relieve obstruction, prevent complications, and maintain biliary flow. Conservative management, appropriate for mild, non-obstructive cases. Antibiotics, treat cholangitis or infections. Ursodeoxycholic acid, in cases of bile stasis or primary biliary conditions. Endoscopic interventions. 1. Balloon dilation, used to dilate the stricture endoscopically during ERCP. 2. Stent placement, plastic stents, often used temporarily, may require frequent replacement. Metal stents, covered, longer patency, and reduced need for repeated interventions. Serial stenting with multiple plastic stents may provide long-term resolution. Percutaneous interventions. Percutaneous transhepatic biliary drainage, PTBD, temporary relief in cases of severe obstruction where ERCP fails. Surgical treatment, indicated for refractory strictures or complications. Hepaticojejunostomy, Roux-en-Y, creates a bypass between the liver and intestine. Choledochojejunostomy, for distal bile duct strictures. Management of specific conditions. Primary sclerosing cholangitis, PSC, immunosuppressive therapy and bile duct dilation, liver transplant in advanced cases. IgG4-related disease, steroids and immunosuppressive agents. Trauma or post-surgical strictures, surgery is often the definitive solution. Adjunctive therapies, photodynamic therapy, PDT, may be used for refractory cases. Biliary drainage, prevents sepsis and reduces jaundice in acute settings. Follow-up, regular monitoring with LFTs and imaging. Long-term surveillance for the recurrence of strictures or malignancy. Complications of untreated biliary strictures, recurrent cholangitis, secondary biliary cirrhosis, portal hypertension, liver failure. Multidisciplinary care involving gastroenterologists, surgeons, and radiologists is essential for optimal outcomes,